Hey everyone, and welcome to this week's episode of the Acuity podcast. I feel as though we've done good groundwork here on getting a sense of my politics, my thought process, my advocacy work, and you're going to start to enter into a much more comprehensive and even in a sense heavier conversation about some of the issues that we face in society pertaining to healthcare and the law. As always, Acuity is best savored over an indulgent and stimulating caffeinated drink, so grab your favorite fix. Black coffee again for me today. A steaming cup of coffee, a refreshing Diet Coke, a soothing tea, or prepare to get sweaty with a pre-workout, and let's get started. On the agenda this week, we'll be talking about informed consent. And like always, we'll do a deeper dive on a healthcare topic of concern. This week, strokes. Today, we're discussing a cornerstone of medical ethics and law, informed consent. First off, what is informed consent? It was eloquently put by Chief Justice Laskin in Hopp v. Lepp. The term informed consent reflects the fact that although there is generally prior consent by a patient to propose surgery or therapy, this does not immunize a surgeon or physician from liability for battery or for negligence if he has failed in the duty to disclose the risks of the surgery or treatment, known or which should be known to him, and which are unknown to the patient. Essentially, it's about a patient's right to decide what's done with their body, hinging on the duty of disclosure by healthcare providers. It may seem obvious today that informed consent is important, but it wasn't always. The philosophy and governance of informed consent has deep roots way into the past. Plato, in 350 BC, suggested that ignorance is the root of all evil, emphasizing that knowledge is important for goodness in society. This is important because we start to set the standard that knowing things is actually an absolute benefit for society to flourish. Thomas Aquinas in 1270, with his Christian humanism, started to argue for the equality of all men, laying the groundwork for ethical considerations in medicine. For example, that bricklayers and masons deserve respect as much as physicians or nobles. That is also important because there is the suggestion that lords, nobles, ladies have a more inherent value, dignity, autonomy than others. But very quickly we are moving out of that. So we are already combining the fact that both knowledge is important and that people are equal. Adam Smith in 1770 spoke to the need for an informed actor in economic and personal decisions. This is mostly from a utilitarian perspective of marketplaces, but the notion of an informed, autonomous actor was taking greater hold in the framing of society. You know, my personal favorite and hero, John Stuart Mill, in 1859, warned of the hubris in science and healthcare specifically, advocating for individual liberties, bringing the theory of autonomy out of the market and into conversations between people and with experts. But there was also always some pushback. Henry de Monville in 1350 controversially suggested hiding the truth is actually a good thing because it leads to a better prognosis. Now that doesn't sound like it sits well, but there was evidence to support that. Telling someone that they're going to die of cancer in a month or two, they are miserable, despondent, and outcomes worsen. What if you hide that from them? It may not seem as though that is a virtuous or moral position to take, but there has been evidence and argument in the past that that is a better method or process in order to give people hope and improve their prognosis. Even as recently as 1847, the American Medical Association leaned towards professional disclosure between physicians rather than to the patient. This hubris of experts and elites took a lot to beat out of our medical framing, but it still raises its ugly head today. Perhaps most famously, when Anthony Fauci said, "Attacks on me, quite frankly, are attacks on science." This is a tremendous audacity, and we have to be vigilant and protect against it. We have to push back in order to continue to maintain and advance that individuals acting autonomously are not only for the singular benefit of themselves, but also for the advancement of society as a whole. This is not only a utilitarian, net improvement for society, but also an absolute moral virtue. Regardless of the theory, practically speaking, informed consent matters. Professional standards and regulators require it as a function of the standard of care. Of course, it's also a legal requirement these days, so it's important to do well to mitigate me and other malpractice attorneys coming after them. More than that, in a market, informed consent leads to happier patients, which entices more business. This may not always seem like it's relevant in a public healthcare system like in Canada, but it is. If patients get any opportunity to say, hey, you know what, I've heard good things about this physician or that physician, if the rate my MD score starts to rise or fall based on the way that the physicians communicate, this can make a big difference. What are the elements of informed consent? Well, it must be voluntary. That means free from coercion. It must be given by a patient with capacity. That means that they are able to understand and process the information that's being given to them. It has to be for both the treatment that's being offered and the person administering it. This is not just specific to a procedure, but also to the provider. Next, it has to be adequately informed. And the onus is on the clinician to ensure the understanding. When we talk about the adequacy of information, that is a tricky part. The process of informed consent begins early, like in an implied consent paradigm. Implied consent can occur through actions like removing clothing for an examination or swallowing medications handed over by a nurse. These ideally should be done as part of an entire conversation. You're coming in for chest pain. I'm going to listen to your chest. I want to look at your chest rise. You've mentioned a deformity. I'm going to examine it, and so on and so on. The entire context of the clinical encounter gives a credibility to the implication of consent. Express consent is different. That's the type that we more commonly think of. It doesn't have to be formalized in a contract. It can just be verbal. There are, however, major benefits of written consent, especially for some particular interventions, like giving blood. For example, it reminds the physician of the things that they should say. It's also usually much more detailed than the practitioner might be able to recall in that conversation moment right then. And of course, because it's written, that is dated and signed and witnessed, that gives it some added legal strength. Lastly, I want to discuss a little bit about the informed part of the informed consent. Historically, as in the case of Mail v. Hopmans in 1967, there was skepticism about patients' abilities to understand complex medical information, both their ability and even the necessity for them to understand. However, by White v. Turner in 1981, the law had evolved to recognize patients as intelligent, mature, and rational individuals, which necessitated clear communication from doctors. What kinds of things should doctors be divulging? Obvious and common risks, generally speaking, don't have to be disclosed unless they turn out to be something of particular significance. If I'm injecting freezing, it stands to reason that involves a needle into your person. If you come in there with a laceration, freezing might be something that is assumed. Those kinds of particularly mundane or obvious things aren't always disclosable. If a surgeon is going to conduct an operation, you know that means that they are going to cut the skin. Any sense of bleeding from the skin or an incision is part and parcel of what should be expected with an operation. Next would be personal beliefs. For example, religious ones. Jehovah's Witnesses are notorious for declining blood transfusions. This has to be considered when giving them informed consent because you need to consider the different options available to them, what are the risks for a bleeding condition, and whether or not they would require a blood transfusion. These people need to be told specific to them and their unique concerns what are the risks, benefits, and alternatives. Then there are what we call material risks. Those are the ones that have a significant chance of causing serious consequences and must obviously be disclosed. Finally, there are what are called special risks. These might be particularly rare, but if they have a unique quality or character that could influence the decision, it must be disclosed. For example, losing functioning of a dominant hand, something that could affect sexual dysfunction. These are really important and they may be very small, but they are very impactful. And so particular attention from the clinician to disclosing those should be done. Lastly, there are immaterial risks, and they are just that, immaterial. If the chance is extremely low and the consequence might be mild or even moderate. Generally speaking, if the risk passes a certain threshold that is determined based on both statistics and expert opinion, then those things don't have to be disclosed. As you can see, informed consent is not just about signing a form. It's about a dialogue that respects patient autonomy, acknowledges the complexity of medical decisions, and navigates the ethical landscape of healthcare. It is a complex topic in law, and it is often hard to prove that informed consent was violated. Not because it wasn't violated, but because the violation must also make an impact on what the reasonable person would have opted for in that situation. So, if you can imagine that something was improperly failed to be disclosed, but that the patient would have made the same decision anyway, then although there was a violation of informed consent, from a negligence point of view, it doesn't cross the threshold for successful legal action. These are tricky cases, and of course, if you're concerned, you should contact an expert who can help you navigate them. Next, we're going to dive into the critical world of strokes, one of the leading causes of disability and mortality worldwide. As both a physician and an attorney, I'll discuss the pathophysiology, diagnosis, and the treatment of strokes, highlighting where medical errors could potentially occur. Let's start with the physiology. A stroke, or cerebrovascular accident, a CVA, happens when cerebral blood flow is suddenly interrupted, either by an occlusion, ischemic stroke, or a blood vessel rupturing, which would be a hemorrhagic stroke. In an ischemic stroke, which accounts for approximately 90% of all strokes, a thrombus from a plaque in the arteries or a blood clot from an arrhythmia blocks an artery, leading to ischemia and subsequent infarction of brain tissue. Basically, a way of saying that brain tissue starts to die as a consequence of lack of oxygenation. Hemorrhagic strokes involve the rupture of a cerebral vessel, causing bleeding into or around the brain, which can lead to increased intracranial pressure and direct neuronal injury. Both types can cause severe functional impairments or death due to the brain's sensitivity to oxygen deprivation. How long different tissues can survive without oxygen is dependent on how metabolically active they are. Some tissues can last many hours. The brain is extremely fragile and sensitive to that. Mere minutes can be enough to cause particularly bad damage. How are strokes diagnosed? First and most importantly is a good history and physical exam. We typically use the FAST test, face, arms, speech, and timing, as a quick screen, but a much more comprehensive clinical picture is necessary. Symptoms can vary widely in strokes, from unilateral weakness, sensory loss, speech difficulties, or even more subtle signs like sudden confusion, vision changes. Ischemic strokes can sometimes present with what's called a TIA, or a transient ischemic attack. That's like a warning that something bad could happen soon. If a physician doesn't catch that and doesn't have it high enough on their radar with the proper interventions, some patients will transform from that event into a much bigger one, and it could have been prevented with medications or other interventions. Along with a good history and physical exam, you have to make sure you don't miss a different diagnosis and start down the path of treatment for a stroke. Checking a blood glucose and electrolytes, for example, can help rule out other conditions that mimic strokes. It's also really important because there are contraindications to giving certain medications and treatments for strokes, and patients aren't always in a position to tell you of those particular concerns or risk factors, especially if they are confused or they may not know. A great example is if you are already on blood thinners. Checking to see what a patient's coagulation factors look like can make a big difference in their risks from stroke medications, specifically thrombolytics. Next up is imaging. A non-contrast CT scan is the initial diagnostic tool to differentiate between ischemic and hemorrhagic strokes, but there are better options in certain situations and they should not be ignored just to preserve resources or because it's difficult to arrange. MRI provides detailed views, especially of the posterior part of the brain, but it takes more time, which is critical in acute settings. Next, scans that include an analysis of the blood vessels, like a CT angiogram, can further assess for both vessel occlusion, dissection, or aneurysms that could be the cause of hemorrhages. Moving on to treatments for ischemic strokes in particular, timing is everything. Some people may immediately think about clot-busting drugs, like TPA or alteplase. Yes, these have a major role, but physicians have to have the right patient at the right time to make best use of them. There is unfortunately the very real risk that they can make things much worse and end up killing the patient. A patient has to be in what I call the Goldilocks zone. Not too sick, but also that the stroke symptoms aren't too minor. The risk-benefit outside the Goldilocks zone doesn't always lead to giving the medications. Next is the timing. The sooner the better, but certainly outside of a critical window, roughly between the 4 and 4.5 hour mark, the value drops dramatically. Beyond clot busters, there is a role for antiplatelet therapy. For example, aspirin and clopidogrel, after a CT scan shows that this is ischemic and not hemorrhagic. Because these can worsen bleeding disorders, you don't want to give it to someone who's actively bleeding. It is also very much worthwhile considering other supportive measures. For example, controlling the patient's blood pressure, but not dropping it too low or too quickly. Making sure that they don't hurt themselves by trying to get up or if they're restless during transfer. These things might seem kind of small, but good care, both by the bedside nurse and from physician orders, can make a big difference to make sure that these patients who are struggling from a stroke don't get worse. As you can see, strokes require careful but quick thinking, which are the conditions ripe for medical errors to take place. Ruling out stroke mimics, diagnosing and treating TIAs so they don't develop into big strokes, the Goldilocks zones for clot busters, ruling out bleeds, and supportive care. That's a lot. Stroke management is a race against time, where every minute counts. As we close, remember, advocating for your health and those of your loved ones includes understanding these nuances. As both a physician and an attorney, my role is not only to heal, but also to ensure that the practice of medicine adheres to the proper standards of care, safeguarding patient outcomes and advancing trust in our medical system. If you have concerns, visit my website at acuitymedicallaw.com, and as always, thanks for tuning in.